Okay. So good morning, everybody. I will be the dessert, and I will present you the end of the study of KEYNOTE-189. Here you have my disclosure. Okay. KEYNOTE-189 is the phase 3 randomized clinical trial. It was a randomization 2-to-1 to receive either the combination of platinum pemetrexed and pembrolizumab and the platinum pemetrexed alone. It has already demonstrated from the first interim analysis a benefit in terms of overall survival, progression-free survival, and response rate, and this benefit was irrespective by PD-L1 status. As it was mentioned before, there are data suggesting that TMB is a good biomarker to select perhaps patients for the single agent or for the combination of anti-PD-1, anti-PD-L1, and anti-CTLA-4, but no data were available until now for patients treated with the combination of chemotherapy and immunotherapy. For these reasons, the objective of this analysis is to evaluate the benefit, the clinical benefit of the tissue tumor mutational burden determined by the whole exome sequencing in the population of the KEYNOTE-189. As you can see here on the left, 616 patients are in the overall trial, and 293 patients were available for the analysis of the tissue tumor mutational burden. The main reason of the attrition were the small amount of the tissue sample to allow a good quality of DNA to test the tumor mutational burden. As you can see, the overall survival, the progression-free survival, and the response rate of the overall population resemble the overall survival, the progression-free survival, and the response rate of the tumor mutational burden available population, suggesting that this can be a good population to draw some conclusion for the tumor mutational burden. We performed two types of analysis. In the first analysis, we analyzed with a pre-specified cutoff the TMB analyzed as a continuous variable. And as you can see, there is no benefit of TMB for the selection of the patients in terms of response rate, progression-free survival, and overall survival. And again, there is no association between the tumor mutational burden and PD-L1 expression. They are two independent factors. Moving to the results, we presented the results for cutoff with 175 and for cutoff 150. They are two pre-specified cutoff corresponding in a pan-cancer data set to potentially to the cutoff of Foundation 1 of 10 and 13. Here you have the results for the cutoff of 175, 13, and you can see that we can find the same point estimate and the same reduction of the risk of death for patients treated with chemotherapy and pembrolizumab and for chemotherapy alone. The same results, consistent results, are found also for progression-free survival and overall survival, where you can see that the combination of chemotherapy and immunotherapy performs in the same way in TMB high and in TMB low. So in conclusion, the tissue tumor mutational burden assessed by whole exome sequencing is not significantly associated with efficacy of pembrolizumab pemetrexed carboplatin, is not significantly correlated with PD-L1 expression. Pembrolizumab chemotherapy had a similar overall survival, progression-free survival, and response rate benefit in both the TMB high and the TMB low subgroups, and our data suggests that the tissue tumor mutational burden may not help select patients who would have better outcomes with the combination of pembrolizumab and chemotherapy given as a first-line therapy for metastatic non-squamous non-small cell lung cancer. Thank you.
Thank you, Alina. it seems we have a clear answer, no, to the question if TMB is able to predict those patients who receive chemo and Pembro. Okay. Questions for Dr. Langer and Dr. Garassino? Please.
Charles Bankhead, MedPage Today. I had a question for Dr. Garassino and for Dr. Langer. What do these two studies taken together have to say about who should be evaluated for TMB and who shouldn't?
I'll start first, and then Dr. Garassino can amplify, perhaps. I think it's still an investigational marker, personally. From my own perspective, just as a clinical researcher, I think the TMB approach to TMB can be divided into two groups, the TMB cultists and the TMB skeptics. Mm-hmm. And I would group myself in the latter, although I still think it has a potential role. We haven't figured it out. I think we have to, it certainly would not be used, at least not yet, in therapeutic decision making. So while I like to know it, I'm not sure I would make a decision yay or nay for chemo or Pembro yet. I do wonder, though, if, and that's why I asked the question earlier about high TMB and high PDL1, is that a group that may selectively do well, particularly well on immunotherapy combinations, or better yet, on IO-IO combinations, and those are data that we've not yet seen. Secondly, I think we have to distinguish between blood TMB and tissue TMB. And it may turn out that blood TMB is a bit more reflective of the entire tumor as opposed to just a single tissue sample. And again, that's just my theorizing. But long story short, not ready for prime time.
So I totally agree that it's not ready for the prime time. I'm sure that we must go to the personalization of the treatments. It is possible that there will be a value for the single agent and also for the combination with the anti-CTLA-4, anti-PD-1, and anti-PD-L1. But nowadays, what we can do in the clinical practice is to select based with PD-L1 status, and chemotherapy plus immunotherapy is the only phase 3 that proved an increase of overall survival everywhere.
I have a question. So, question for the panel. So, I know Dr. Rizvi is not here. In his presentation, his high TMB was 20 mutations per megabase. Fabrice's is 10. And then these other two is actually a completely different definition, 175 mutations per exome. And I think herein lies the problem. We are not even talking about the same thing. And I wonder if they can comment on that. I mean, normally in medicine, if we have a biomarker, an EGFR mutation as on 19 deletion, we are all talking about the same thing. You know, assay sensitivity might be slightly different, but we know what we are talking about. But if you tell me high TMB, I don't know what it means because everybody defines it as differently.
I pretty much agree with you, Alex. I think, remember, TMB is not the target of these drugs. PDL1 is. And it's a surrogate, perhaps a surrogate for immune load for neoantigen. There are so many different ways to do it. NGS may not be as good as whole exome sequencing. Really, to determine TMB, you need a whole exome sequencing. And the blood-based markers, as I said earlier, may ultimately pan out better. But there is, as you point out, absolutely no consensus on which approach to use and what the cut points are.
Yeah, I totally agree. They are two different tests, but at a certain point we will need to harmonize the test if we want to introduce it in the clinical practice. The best, in my opinion, is the whole exome sequencing because the other one is different. But if you look at the cutoff, you can see that there is a benefit every time with the single agent with TMB high. You just increase the size of the magnitude of the effect as much as you increase the TMB. So I think that we have a lot of work to do.
Yeah, it's clear. It's just a matter of sensitivity and specificity of the test you are looking for. It's a continuous biomarker. Then if you put the cutoff very high, of course you will select a patient population that will for sure or almost for sure respond to the immunotherapy, but it will represent only a very, very small part of the patient. And if you decrease the cutoff, then you have a more heterogeneous group with patients who respond. The selection of the patients is, of course, less evident. And it's why I think this kind of cutoff and the selection by the TMB is so complicated as of today.
Okay. Any more questions? If not,